here at MDA. We're super excited to be talking to you all about your options for healthcare in the coming year. As we've had some new things passed, some rules change, and of course, the wild world of open enrollment beginning for all of us once again. Um, so super excited to talk to you all about that. We've got some great guests, and all in all, it should just be very informative for everybody. So as we get started, let's run you through the agenda. First, we will introduce you to our lovely panelists, and I'll run you through some quick housekeeping to let you know how this is going to operate. After that, I will turn it over to Jennifer, who will be giving us a deep dive over recent insurance changes in the public policy world. And then I will be handing it over to Jane, who will be talking us through the view on the ground. And then we'll give you some additional resources and give you a chance to ask some questions as well. So in terms of housekeeping, there are two options for asking questions as we move forward. There is the regular chat box that we're all probably familiar with, but then there's actually, if you go over to the very far right of your screen, past that chat bubble, you will see 3 dots that is panel options, and there you will see a Q&A button. And if you type your question into that Q&A box, then we'll be able to more effectively answer your question, because then we can mark them as answered as we move forward. But if that ends up being complicated or you can't find it, feel free to just throw them in the chat. It happens all the time. And then if anyone needs closed captioning, there is a button for that on the other end of your screen. They're at the bottom on the far left. So let's meet the panel. First and foremost, we have Jennifer Dexter. Jennifer is a lifelong DMV resident with over 20 years of experience in the public policy space. She is currently the Assistant Vice President for the National Health Council, where she helps member organizations develop and establish policy positions which seek to improve the lives of people with chronic diseases and disabilities. Jennifer earned her BA in political science from Washington University in St. Louis. Next, we have Jane Sladen. Jane joined the National Psoriasis Foundation in 2019 with more than 20 years of healthcare experience in ambulatory clinics. She is responsible for the Patient Navigation Center, the Outreach Department, the Volunteer Program, and Health Education Materials. Jane received her Bachelor of Science degree in Speech Pathology and Audiology from Oregon State University. And you have me. My name is Joel Kartner. I'm Director of Access Policy here at MDA. So I handle all things access to healthcare, devices, drugs, specialists, anything and everything in terms of accessing healthcare on the ground here at MDA. So now that you've met everybody and everybody's all settled, I will hand it over to Jennifer to get us started. Jennifer, you're on mute, I think.
So embarrassing. I'm so sorry. Thank you so much. I'm so happy to be here, Joel, and thank you for having me. My goal, as I understand it today, is talk to you a little bit about the current state of coverage and changes that are coming down the pike. So I thought I would start with just a brief overview of Medicare versus Medicaid. I suspect many of you know this, but it's always good to make sure we're all kind of level setting on the same thing. So Medicare is a federal insurance program. Medical bills are paid from a trust fund that people have paid into through federal taxes, your FICA line on your paycheck over the years. It primarily serves people over 65, whatever their income. So it's not what they call means tested. Patients pay part of the cost through deductibles for hospital and other costs, small monthly premiums, things like that. It's a federal program. It is basically the same for everybody in the United States and run by the Centers for Medicare and Medicaid Services, or CMS, who is an agency of the federal government. There's a subset of Medicare plans called Medicare Advantage that I'm going to talk a little bit later about. But Medicare Advantage, that are sometimes called Part C or MA plans, you may hear them referred to, are offered by Medicare-approved private companies. So it's kind of private Medicare. They have to follow the rules, the same rules of Medicare, and they have a little bit more flexibility within that to try and figure out. They tend to pay for more kind of preventive services or wellness services, those kinds of things. Most Medicare Advantage plans include drug coverage, and in some cases have many more rules around who you have to use in network or out of network. So I just want to touch on what Medicare Advantage was. So that compares to Medicaid. Medicaid is an assistance program. It serves low-income individuals of every age. Patients usually pay no part of the cost for covered medical expenses or a small copayment. It's a federal state program. As I said, Medicare is all federal. Medicaid is financed and run by a combination partnership of the federal government and your state government. So the rules can vary greatly from state to state and depending on where you live. And even the who qualifies for Medicaid in various states can vary greatly. I'm going to talk a good bit about prescription drug coverage because there are a lot of changes coming there. So under Medicare, it's Part D is what we refer to prescription drug coverage for. You purchase it, you pay a premium, a yearly deductible, the same as you would for any insurance, but it's affordable and has to abide by the rules of Medicare. Medicaid does not pay for drug coverage, but it only covers it if you're in a nursing home or assisted living. So we really don't view Medicaid as having a significant drug benefit the same way Medicare does. So that's just to level set the difference between the two things that I'm going to talk about significantly. So the next thing I'm going to talk about are the Medicare changes that are on the way. You've probably been reading a good bit and seeing a good bit about the Inflation Reduction Act, a pretty sweeping piece of legislation that was passed in August that, among many other things, makes significant changes to Medicare, and particularly the prescription drug side of Medicare. So what's heading our way and when? The big news for beneficiaries is that beginning in 2025, the maximum amount that they will have to pay out of pocket for prescription drugs each year will be $2,000. There's a couple details within that. The out-of-pocket limit applies if you get your prescription drugs through a Part D plan or through Medicare Advantage, however you get your drug coverage through Medicare. The amount of the cap may change over time depending on what Medicare Part D spends on prescription drugs per enrollee. So that $2,000 a year cap over time could grow a little bit. If your Part D plan or your Medicare Advantage prescription drug plan has a deductible, that will count towards the cap. So if your deductible is $100, once you've met your out-of-pocket costs, you'll be capped once you've spent another $1,900. So really anything that you as an individual would pay out of your pocket would count towards that $2,000 cap. So as I said, the out-of-pocket cap takes place in 2025 is when it kicks in. But in 2024, they've developed kind of a workaround. So essentially, really that $2,000 cap will take place in 2024. It's a little bit different, but for your end user kind of experience, you're not going to see much difference. So even though the rules in 2024 are a little different, you'll still have a $2,000 cap. Another change to the Medicare drug benefit that begins in 2025 is the requirement that Part D plans offer enrollees the option of what's called smoothing their cost. This means that for that $2,000 cap we talked about, you can opt to have your out-of-pocket costs spread out over the year and make a monthly payment towards that. So the maximum a monthly payment would be about $260. This is designed to protect people from being hit with such a big drug bill at one time. We talked a lot about this, about how while $2,000 cap in a program that had never had an out-of-pocket cap before, even though private insurance often does, other programs often do around drugs. $2,000 for that, to be hit with that bill at the pharmacy counter can still be pretty painful. So the idea that you can spread it out with monthly payments is designed to take a little bit of that, ease that a little bit. A couple other changes that are coming the way around Medicare. According to the new law in 2024 and continuing through 2029, Part D premiums can only increase by no more than 6%. So that kind of caps an expectation of what premium increases might look like every year. In addition, low-income subsidy, which are financial assistance for folks who are low-income for Part D of Medicare, it makes the threshold for qualifying for that better for people. So instead of 135% of poverty, it'll be 150% of poverty. So overall, really, some of the most significant changes that are coming in Medicare are around that Part D drug benefit. Okay, moving on to Medicaid. Some of the changes that are coming around Medicaid are related primarily to some relief that Medicaid recipients got during the public health emergency around COVID. At the start of the pandemic, Congress enacted the Families First Coronavirus Response Act, which included a requirement that Medicaid programs keep people continuously enrolled through the end of the month in which the COVID public health emergency ended. So the concept behind this was that we didn't want to be kicking people off of their insurance in the middle of a public health emergency. Primarily due to that continuous enrollment requirement, Medicaid enrollment has grown substantially compared to before the pandemic, and the uninsured rate has dropped. And I should note that the federal government, in order to pay for these folks, the federal government is pitching in a little bit more of Medicaid funding and not dropping that all on the states. So we have all these folks newly on Medicaid, but when the public health emergency ends, millions of people could possibly lose coverage and reverse those gains in coverage. The current public health emergency was currently extended until January 11th, 2023. And the Biden administration has indicated that they will provide a 60-day notice before ending the public health emergency. So if it's going to end in that January date, we should be hearing in the next several weeks about what's going to happen with that. So the CMS is working with states to make sure that what people are calling redeterminations, which is the idea that all these people that are on Medicaid who haven't been reevaluated for eligibility will be reevaluated and kicked off if they aren't still eligible. They are working with the states and provided them guidance to allow them to initiate redeterminations for a whole year after the end of the public health emergency. So that does not mean all states are going to take that long, but it does open up the opportunity for those states who don't want to rush to do all these redeterminations and want to keep people insured to keep them on the rolls for a while and do it kind of in a more deliberative process. Not all states are obviously going to take advantage of that, and some will be processing those redeterminations very quickly once the public health emergency officially ends. So coming up, so I have here the 2023 Notice of Benefits and Payment Parameters. That is a rule that the federal government issues every year that really lays out what are the changes in the ACA marketplace, which is the place where people go to purchase quality insurance that is often subsidized and benefits. So it's Obamacare or the ACA. If you're purchasing through the federal marketplace, these are the rules that plans there need to abide by. So one of the good things is that millions of Americans will continue to be able to afford their individual health insurance under the Affordable Care Act because the Inflation Reduction Act extends expanded premium assistance for the next 3 years. So this is additional assistance that allows people to offset what their premiums are going to be and make health insurance more affordable for people with lower incomes. The American Rescue Plan, which we passed in 2021, enhanced premium subsidies for the ACA plans, but that additional assistance was scheduled to go away at the end of 2022, the end of this year. Had they gone away, the nonpartisan Kaiser Family Foundation estimated that about 33 states that use the ACA's federal health insurance marketplace, premiums would have gone up 53%. The foundation also predicted that more than 3 million Americans could lose their health and coverage if the subsidy support wasn't extended because they couldn't afford the premiums. So the success of getting that premiums subsidies extended to the end of 2025 was a victory. One of the things that we will continue to work on is looking at how we can continue that progress. If you're sensing a theme here, really a lot of the work that's happening in Washington right now is making sure that the widest swath of people possible have access to some accessible, affordable insurance options. So when the NBPP comes out, the rules, there's a couple of trends that we have seen that we think are going to play out in the next cycle of 2024 plan rules. We think there will be some attention paid to shoppability. How do people navigate getting information about their options on different health insurance plans, making the right choice between those plans, and then navigating the plan once they have it. Just making them more user-friendly, more consumer-friendly, and getting people the information that they need to make good decisions and being more transparent. There is a focus on what are called standardized plans, which is making sure that everything offered under the marketplace meets some minimum standards and certain quality and including certain services. There's a growing attention to looking at health insurance brokers and how they work with individual consumers and making decisions about their health insurance. And making sure that they are directing people towards information that is about quality plans and not shortchanging them, those kinds of things. There's a continued theme in many of the rulemakings CMS has been doing around health equity, making sure that they are putting things in place to close the disparity in health for marginalized populations. And then finally, another trend is improvements in mental and behavioral health, and particularly making sure that what we call network adequacy, which is the kinds and types of providers that health insurance plans have available are adequate to meet people's needs. And mental and behavioral health is an area where that's seen as needing attention. Okay, and then finally, moving to some other areas where we have seen CMS paying some attention that we think will be topics over the next not too distant future. The first is finding coverage options for people who live in those states that chose not to expand their Medicaid eligibility up to the level that was set in the ACA. The Supreme Court made decisions after the ACA was passed to leave those decisions to the states. And there are several states who have chosen to continue to have people kind of fall in the gap between those people that get help in the ACA marketplace and those people that are eligible for Medicaid. And making sure that those people get some attention is a trend we are seeing. Increasing access to home and community-based services. At the end of the day, Medicaid is really one of the few insurance options that provides coverage for home and community-based services and long-term services and supports. You'll hear about people spending down to be eligible for Medicaid in order to access the levels of care they need. That balance in Medicaid has always kind of been off in institutional versus home and community-based care. So continuing to work to rebalance that is a focus. And then finally, I mentioned earlier about Medicare Advantage, which is basically privatized Medicare. There is a growing attention to the fact that that market is growing very, very quickly. We have passed a tipping point where over half of Medicare beneficiaries are in Medicare Advantage plans and not the traditional one offered by the federal government. So making sure that protections and access and equity and the kinds of coverage that people need are continuing to be available under Medicare Advantage. And what that means for specific populations in particular is an area of we've seen CMS asking for input and guidance on. We don't know how that will play out, but that concept of looking at Medicare Advantage plans and making sure that they're achieving what they need to achieve given their growth and the percentage of coverage that they offer is another trend. All right, I think I've got that was a lot. I know I just dumped a lot on everybody, but hopefully that gave you a good overview of kind of where the trends are and what's coming in both the immediate and not too far future. So thank you.
Thank you so much, Jennifer. That's a really great overview of what's happening as we move forward. I do want to throw you one really quick question from the chat. Vin asked a really good question, which is, what preventative services can be covered by insurance plans such as physical therapy? Usually insurers deny services after 5 or 6 sessions.
Did you say preventative services? Sorry,
Yeah, preventative
my audio's
services.
not good. Yeah, I think it varies greatly. One of the things that I have found very interesting is the privatization. So many states have worked with private insurance companies to privatize their Medicaid program and Medicare Advantage that I mentioned. Both of those have kind of interesting incentives to do a better job covering preventative and wellness kinds of services. It's one of the benefits. There are a lot of concerns with privatization, but I think it's one of the really interesting things there. The kind of traditional Medicare and state-run Medicaid programs don't have as much incentive to think long-term about that because they are predictable and judged on short-term budget cycles. And so Medicaid pays some preventative services. Medicare actually has more requirements on broad kind of general preventative services, things like screenings and testing that goes on. Medicare has the ACA actually put some requirements on Medicare that they cover those kinds of preventative services and that they're required every year, which has been a very good thing from my understanding with some of the disease groups. So they all have different, depending on whether you're in private or public, Medicare or Medicaid, and whether you're in Medicare or Medicaid, they have different incentives and different requirements. That is definitely where insurers are heading. I think they're starting to even have greater understanding of the value of those kinds of services, both financially and just kind of in competitiveness for themselves. And so it's going to vary greatly depending on the program you're in, who's providing it, and whether it's private or public.
Yeah, that makes a lot of sense. Thanks so much. And with that kind of level set, knowing where the ground is from a policy perspective, we're going to turn over to Jane to talk about what you might see on the ground. So as a starter, Jane, in all the new reforms that Jennifer laid out, is there anything people should be particularly aware of? If there's like one top of mind thing.
Oh boy. I would say that the biggest thing to be aware of are the two changes that Jennifer laid out in 2024 and 2025. So, and they can't come fast enough from what I can tell. In 2024, you have currently you have a catastrophic coverage phase of Medicare, and currently any co-pays or co-insurances that you have to pay during that phase, you still have to pay them, but it's at a lower rate. The good thing in 2024 is those copay and co-insurances you won't have to pay on your prescriptions when you're on that catastrophic coverage. So it's starting to lessen the out-of-pocket burden on people with Medicare. And when you're on catastrophic coverage, that's something that if you're in a disease state like with psoriasis or psoriatic arthritis, which is what we deal with, the people that are on biologics or oral systemics they have a lot of responsibility and burden when it comes to affording their treatment. So being able to lessen that burden is going to be great. And then that cap, the out-of-pocket cap with the smoothing mechanism in 2025 is going to be fantastic. Even without the smoothing, I know some of our constituents, they can easily meet that out-of-pocket cap of $2,000 within the first month of being on one of their treatments. So that's really exciting news that we're getting closer to where people on Medicare are able to better afford their medications. It's a big shock for people that are transitioning from their commercial insurance to Medicare to find out that they are no longer eligible for those wonderful copay cards that the drug manufacturers offer. So it's going to be nice to have a little bit more help for them, definitely.
Yeah, a lot of exciting stuff coming for sure. Mark, we can go ahead and move forward. So, with that said, let's start with Medicare. Can you explain the differences between Medicare and Medicare Advantage and non-Advantage plans?
Well, Jennifer touched on it a little bit, and I'm grateful for her to give that introduction there. So Medicare is divided into several parts, and we're used to hearing about Part A, which is the hospital insurance. It covers things like hospital visits, skilled nursing, facilities, home health, hospice care, things like that. And then you have Part B, which is the medical insurance. And that's going to cover your doctor's visits, the DME, the durable medical equipment, lab tests, x-rays. Most people, when they sign up for Medicare, if they're just doing Medicare, they will have Parts A and B. And you notice in all of those that I mentioned, nowhere do you talk about prescription costs or prescription drug coverage, because that's under Medicare Part D, as Jennifer had mentioned. So Medicare Part D plans are not included automatically with Parts A and B. If a person wants to get that, they would have to go through a private insurance company, which follows those rules that are set by Medicare. The other bad thing is that you then end up paying a monthly premium for your Medicare Part B and your Medicare Part D. So that's original Medicare, as we call it. Medicare Part A and B together makes up original Medicare. And then you have Medicare Part C, which is the Medicare Advantage plans. And the Medicare Advantage plans, like Jennifer mentioned, are offered by private insurance companies, and they replace original Medicare. So you have the Parts A and B, it's rolled into Medicare Part C, but you also have that opportunity to have other benefits, and some of these can be automatic with your Medicare Advantage plan, which is really great, so that you can have things like dental and vision and that prescription drug coverage. The nice thing about the Medicare Advantage plan is that you may have just one monthly premium that you'd be paying instead of the two if you're on original Medicare and you have the Part D. One thing I like about the Medicare Advantage plans is that if you look carefully, you may end up with a plan that has no monthly premium. So here again, it's helping to reduce those out-of-pocket costs that people on Medicare have. So those are the big differences between Medicare and the Medicare Advantage plans.
Thanks, that's really helpful. And I mean, Medicare is intensely complicated, so being able to navigate parts A, B, C, and D that concisely is really a feat, let me tell you. And so that's actually all we had on Medicare. So now we can move forward to Medicaid, where the fun also never stops. So how can people manage a change in their state residence when they're on Medicaid?
Well, I would suggest going to Medicaid.gov because there you can find out, they've got a nice little map and a list of all of the different states with their different Medicaid agencies. And as Jennifer mentioned, Medicaid is a combination of the federal and the state. And so the plans vary from state to state. So what you may be having in where you're currently living, the eligibility may be different to the state you're moving to or where you're changing. So definitely go to Medicaid.gov and look for the map of the different states and figure out who you need to contact, hopefully before you have to change, so that you can see if you are eligible.
And speaking of which, Jennifer dropped a very nice map in the Q&A box that can help you figure out whether or not your state is an expanded access state or not. So do feel free to take a look at that as we move forward. Continuing in the Medicaid bucket, if you get insurance via Medicaid, what are some key things to remember this fall?
For Medicaid or Medicare and Medicaid?
Let's go with both. Why not?
Okay. I would say that across any of these, whether it's through Medicaid, Medicare, or through the marketplace, if you're on a monthly treatment, like whether it's a biologic or an oral systemic or any type of treatment like that, take a look at the formularies. So the formularies are a list of the drugs that are covered by that insurance, and those change. So that is the key thing, is take a look at those and make sure that the drugs or the treatments that you're on are on that formulary. Or if you're during open enrollment, take a look at the others to see which other ones you might want to switch to, what other plans. Can't do that too easily with Medicaid, but certainly with Medicare Advantage plans or any plans through the marketplace, you could take a look at that. And I think the other thing for Medicaid is to make sure that your state Medicaid office has your current address, because they're going to be sending out letters for renewal, important information. You don't want to miss those, especially with what Jennifer mentioned about the redetermination that could be coming up here. You want to make sure that you get all of that information. Don't assume that they have your current address. Be proactive, go out and contact the office and make sure that they do have your current address. So I think the bottom line I have on all of the insurances is take the time to compare plans. If you have options, compare them, see if your doctors, your specialists, your treatments are covered. So all of that is very good to compare.
For sure, definitely. So as you know, and as we all know, when you're navigating insurance, occasionally requests for coverage, especially under Medicare and Medicaid, do get denied by insurers every so often. So how should people handle their insurance denials? Is there any particular reason why they happen? And is there a proactive approach that you can take to minimize the potential of your request for coverage being denied?
First off, when you get the notice of denial, don't just think, oh, that's it, I'm done. I have nothing else to do. I have no recourse. That is definitely not the case. So when you do get an insurance denial, the insurance company should be sending you a reason, the why. Why are you getting this denial? And it can change. It can be for a variety of reasons. Some of them, especially for treatments, would be that it's not covered under their formulary, which I already mentioned. The treatment or the procedure may not be viewed as medically necessary by the insurance plan. Or, I love this one with all the different treatments out there. Your insurance company may want you to try a more affordable option before going to what your doctor has prescribed. And I'm sure some of you are already aware of this, but that is called step therapy. And it is a huge portion of denials that we see in the psoriatic disease community for their medications. But as I said, don't stop. Don't stop fighting. You've got to be an advocate for yourself and bring your healthcare provider in to be an advocate for you. Frequently, when you're appealing a denial, the provider is going to need to write a letter as to, why is this medically necessary? Or, it's we can't do step therapy because we've already tried and failed on these other medications. So you want your provider to be the advocate for you also. And they're going to be writing those letters to go with all the paperwork for these denials and your appeals for it.
Yeah, that should definitely help some people out around denials for sure. So we've covered Medicaid, we've covered Medicare, we've covered denials. Now let's kind of get into some quick tips for people as they move, in the ACA, as we move forward. So under the ACA, if you get insurance via the ACA marketplaces, what are some key tips to remember during open enrollment?
Oh, let's see here. I think here again, it gets back to during open enrollment, take a look at the formularies. Make sure your treatments are covered. Make sure your providers are covered, even your specialists. They can change too. There's nothing worse than going to a specialist and then finding out that, oh, great, it's not covered this year. And when I say covered, if you're on a plan where you have in-network providers, that's what I'm talking about. You want to make sure those providers are in-network. You could certainly, under some plans, see providers that are out of network, but that will cost more for you out of pocket, most likely. So check those plans, check the formularies, and make sure your providers are definitely still covered. And I guess one other thing, which I hadn't thought much about, but it does change and it sneaks up on you, the copays and coinsurances. A lot of people don't take the time to look at that. I know myself, they used to put that nice and clear on your insurance card, what your copay was. They don't do that much anymore because they can change it a lot quicker if you don't put it on your insurance card. So take a look at that. Make sure it's where you're comfortable paying for that, because that's another out-of-pocket cost.
Definitely. And McKinsey, apologies if I'm mispronouncing her name, but they ask a very good question. Are there any terms or phrases or any magic words that you should use or your doctor should use to help increase the chance of your denial being overturned?
Really good question. I don't know of the magic word. I'm still searching for it. Once I do, I will let everybody and all patient advocacy organizations know about it. But some good tips, especially when you're working with your provider for him or her to write the letter. It's really helpful to make sure your provider understands exactly how your disease is affecting you and impacting that quality of life. I mean, when you see your provider, you work with them, work with getting treatments, you talk about your pain, things like that. But go a little further in depth and talk about how is your disease state affecting your ability to work? How is it affecting your sleep or your self-esteem? For those of us in the psoriatic disease community, having the visible plaques is huge with self-esteem and self-confidence, and it can affect a person different ways on different days. So have that honest conversation with your provider about the impact of your disease state on all of the areas of your life. It's a lot easier for your provider to write supporting documentation if you say, instead of saying, oh, yeah, I get a lot of pain. If you say, I'm in so much pain that it prevents me from, working at my desk day to day, or whatever those concrete examples are, that's very helpful for them. I think the other big thing, and this is kind of mundane, but it's amazing how quickly time can fly when you're dealing with these appeals, and that's to make sure that you meet the deadlines. Follow up, send in all the information. If you're not sure what the deadline is, to get the information to them, call your insurance company and ask them about that. I know how quickly things can get out of hand, and you think, oh, yeah, I got this denial, I got time to work on it, and you put it aside, and then day-to-day life gets in the way, and then you come back a week or two later and go, oh no, I got to start working on this. So don't let that happen. Stay on top of those things, get them put in so that you're able to answer other questions that the insurance company may have and move this whole appeals process along.
Definitely. So I want to be mindful of time and get to the Q&A because there are a lot of great questions coming in both through the chat and the Q&A. But I do want to address two quick tips that we wanted to highlight for everybody through two questions. The first of which is, let's say you make enough money that you don't qualify for Medicare and Medicaid, but you don't make so much money that you can easily afford health insurance. Are there options for you when you're trying to enroll in a coverage plan if you are low income, but not so low income that you qualify for a CMS plan?
I always start with healthcare.gov. That is a great place to start comparing the plans. They have different levels depending on what type of coverage you're comfortable with. I know as I've gotten older, I prefer to have a little more coverage and pay the higher deductibles. But healthcare.gov is a great place to start out for your looking of low cost options. I will also highly recommend organizations such as MDA and the National Psoriasis Foundation, any of the patient advocacy organizations. Go talk with them, call them up, find their help desk, or in our case, we've got a patient navigation center that people can email or call, and there's a team of navigators that'll help guide them through the process. And thank you for whoever put that link in for healthcare.gov up there.
I would say it's just to add the changes that have happened in healthcare.gov. I would say if you're somebody who had looked in there a couple of years ago and it wasn't affordable for you, the way they are subsidized has changed so much, particularly for the next several years. It's worth relooking and to see whether it's become a little bit more affordable for you. So I would just recommend that. And Jane did say the magic word, which is navigators. There's great resources and patient navigators that you can look up on the CMS website. They'll help you get local help navigating all of these systems.
And your navigator is also going to really help you out with finding the right plan for you, let alone an affordable plan in terms of comparing various plans across silver and gold plans or what have you. So definitely leverage those navigators as much as you can. So now we're going to move into the Q&A a little bit more formally and grab some questions both from the chat and from the Q&A box. And I saw one up here. What is my primary if I have a Medicare Advantage plan and the default as I say Medicaid? And that comes from Liz.
I believe it is the Medicare Advantage program, but what they recommend is that you hold on to your Medicare, the red, white, and blue card, as you still need proof of that. That's your kind of Medicare eligibility. So that's my understanding. Don't take me to the bank on it.
And then, so Brian actually asked a really good question, which is why do manufacturers not allow Medicaid users to take advantage of the word I'm looking for, of rebates from those manufacturers? And the really short answer to that, and feel free to jump in here if I miss anything, but the short answer is those discounts are covered under the 340B plans. And so the government doesn't want manufacturers to be dealing with duplicative discounts essentially. And so they silo those two programs away from each other is kind of the short answer.
Yeah, it's the anti-kickback law. So any federal insurance companies, any insurance companies that have federally funded cannot take advantage of any copay cards or things like that. So that's Medicare, Medicaid, TRICARE, things like that.
And MDA actually has a lot of really great resources for navigating your health insurance. So I'm actually going to toss it over to Mark really fast so that he can talk you through a couple of things.
Thanks, Joel. That's good. There's so many questions coming in. I think having the team here kind of assess them for a couple minutes will be helpful. So as they assess some of all the questions we got in, I wanted to talk about a couple resources that could help you. If you're navigating, not sure how to get the proper insurance for you. First, MDA just rolled out a health insurance access to coverage workshop. Um, and this is a step-by-step workshop that you can go through to help you understand anything and everything about health insurance. Everything from what is a medical bill to avoiding surprise medical bills, to advocating for yourself, to navigating through denials, all sorts of things that came up in these questions. MD actually just came out with a new insurance access workshop that you can utilize. It is free. So I'm going to put this in the chats, and you can choose any topic you want. You don't have to do the whole thing. If there's just a topic that it really gets you going or you want to know about, this is a resource for you. So feel free to use this to learn more about your options and how to navigate this understandably confusing system of insurance and care. So this is for everyone. It's free to use. It might be able to help you out as you navigate. Second is MDA's Resource Center. So a lot of these questions that you are coming in with are wonderful. And our Resource Center can help with some of these questions you have as well. So obviously anyone on this panel can help for sure. But if you want to contact us at MDA, we can help you as well. And this is also a resource for everyone on this call. So you can contact us in two ways. You can call us at 800-572-1717 and click and select option one. You also can email us at mda@mdausa.org. So if you have any type of coverage questions, you can contact us, and a member of our resource center, who are just wonderful, will get back to you and help you out. Now, we saw a question coming from Lucy about, do we recruit advocates or find advocates that help us solve some of these problems that some of you are facing? And the answer is yes. So if you're interested in our legislative advocacy program, you can email us at advocacy@mdausa.org as well. Also, if you have any questions that came up from today, you can email it at that box. I check it personally multiple times a day. And if it's something our resource center can help you with, we'll forward it to them as well. So again, two amazing resources. One is our access to coverage workshop that can really answer some of these questions. Again, it's free to use. It's free for you to use. And then our resource center that you can contact that as well. That can help you out. So I wanted to pop in real quick there, Joel, to let you know there's a couple resources. And I'm going to turn it back to Joel because I'm sure a bunch more questions came in. So Joel, I'll turn it back to you.
Yep. And there have been a lot of really, really great questions. Thank you all so much. And if we don't get to your question, as Mark said, feel free to email the advocacy inbox and we'll get you an answer for sure. So Nancy asks, can you speak about any changes in both Medicare and Medicaid to rehabilitation services and skilled maintenance to those with chronic neuromuscular conditions? So I think skilled care is going to fall under Medicare Part A, unless
Yes.
I'm mistaken. And I don't know that there have been a ton of changes there.
Yeah, not a lot new in that area, unfortunately. Something we were pushing for some, but
Let's see. Top of the box. We did get a question about durable medical equipment that I will answer offline because frankly that gets very complicated very quickly.
a whole other can of worms.
I promise you I will email you on that. Let's see. That one. How do managing long-term plans fit into Medicaid? And are there any companies that Medicaid works with that are better at approving services like PT and OT? That's from Mackenzie.
The nature of Medicaid is that it's going to vary greatly, not just between plans and who the insurer is, but also the state you're in, what the state has kind of authorized the private insurers to cover under Medicaid. I can make a case that I think some of the private Medicaid programs do a little bit better job of understanding some of the rehabilitative and preventative services. They have some different, just kind of different incentives and business model. So unfortunately, I don't have an answer for you around who is best. I will say that, and again, it's also going to vary state by state around what kind of what kinds of those services are going to be covered. The way Medicaid is set up, there are a series of required services, and those are primarily kind of primary care, hospital care, and institutional care, so nursing homes and assisted living and things like that. In-home independent living and supportive services are optional, so it depends on what your state has chosen to kind of take up under their Medicaid program. So it's a little complex.
Yeah, and unfortunately, a lot of the answers around this are it's really complicated and it's state by state.
Yeah, this is one of those ones where it's really smart to go talk to a local navigator to help you understand some of that.
And Vin asks a really good question, which is, what does look carefully mean in the context of no premium Medicare Advantage plans? Could you give an example?
You want to take that one, Jane?
Yeah, I'm sorry, could you repeat that one, Joel?
What does look carefully mean in the context of no premium Medicare Advantage plans? And could you give an example?
Well, when you go to Medicare.gov, what I love about that site is that you can go to compare plans, both just original Medicare, and then you can also do Medicare Part C, the Medicare Advantage plans. And you can do it by where you live. So you put in your zip code and what type of plan you're looking at, and it will give you a list of the plans that are available in your area. And you have to really kind of look carefully at those to see, well, this one looks pretty good, but you need to take a look at all of the items in there. You know, it may look good, but boy, that's a huge out-of-pocket cost, the maximum deductible that you have to meet. Or, wow, it says that I don't have anything here for drug costs, but is that true? You have to kind of dig down, find out what the copays are. So look at all of the different areas that they mention on that when they're comparing the plans. And when you're looking at it, if you're not quite sure what a term means, click on it and it will give you a definition, a very clear definition. I have to say I'm very impressed with all the changes that Medicare.gov has put into their website. It's gotten much easier to navigate through and to figure out what plan really is best for you. And over onto the side, it will even have a little checklist of, yes, we cover, if you're on a Medicare Advantage plan, it may say, yes, we cover the vision, we cover dental, we cover over-the-counter products. So look carefully at every little bit on the screen when you're comparing plans. And the nice thing also is that you can include comparing your treatment options. So if you're looking at a couple different plans and you're kind of hesitating, one might be better than the other, put in your treatments. See if there's if there's anything that one plan covers that the other one doesn't, or one covers better. So all those little bits of information you put in gets you better to a plan that it will fit you better.
Yeah, Medicare.gov really is not the gold standard, but the model that we're trying to push even more plan information towards, because it's clear and concise, and you can get in and kind of explore that way, and you can't always do that in some of the other websites or comparison tools.
And it's large enough print that you can actually see it on your computer screen.
We make the case that every other marketplace and website is designed for people who are kind of typical users of healthcare and looking for trying to get something that balances their premium and deductible, kind of hitting that balance. Whereas the reality for a lot of people with chronic diseases and disabilities, paying a higher premium with a lower deductible may make a lot of sense. Whereas if you're a 25-year-old person with not significant health needs, you might want to save that money and on premiums. So Yeah, it's human nature to choose the one that has the lower cost per month, but if you're setting yourself up longer term for getting hit with some big bills, it's an issue.
And a few questions came to me privately, just that I'll make sure we get in. I think this is a Medicare versus Medicaid question, which always it's very confusing. If someone needs something like home support, just as a wheelchair, help with their putting clothes on, or maybe help for medical equipment, which of the like wheelchairs, which of the Medicare or the Medicaid would be most likely to cover something like that?
Ooh.
If is it probably might just be depends, but this is a very common question we get a lot actually.
It's actually interesting because I think, and correct me if I'm wrong, Jane, but I think the issue around mobility devices and durable medical equipment, Medicare, maybe slightly better. The issue for assistance with activities of daily living, things like personal attendance and help with bathing and dressing and things like that, Medicaid may be better off. So it depends specifically on your needs and
And
your
then
eligibility.
also looking at the Medicare Advantage plans may offer a few more things.
Yeah.
And one more that came in, he's mentioned a few times about a navigator to help you guide yourself. Where do you find one?
I bet.
Different places. You can, if you're on healthcare.gov,
Hmm.
if you scroll, I think down to the bottom of the screen,
Mm-hmm.
it's actually a place where it says local help. And if you click on that, you can get to people that are in your area that can help you
I'll
navigate.
put it in the.
You're
I'll put
gonna,
it into the chat. Yeah.
thank you.
There's the link.
Yep. And then, like I mentioned, the patient advocacy organizations, you're going to find someone there that would be able to help guide you through it. They may not be able to give you specific answers for different plans, but they can certainly guide you to the people that can.
And they can help you with the kinds of questions. They know the issues that somebody with muscular dystrophy or psoriasis or whatever might face, so they can give you kind of even the help navigating the navigators, if that makes sense. What are the questions you want to ask, things like that.
Yeah.
Sorry, I had some sirens on my side that you might still be able to hear actually. But that is actually all the questions that we've gotten, and we've got just a little over 2 minutes to spare. So I'll say a quick thank you to both of you. I think this has been a massively helpful webinar for people. Do either of you have any closing thoughts?
Take advantage of open enrollment. If you are
Yeah.
looking for change, do it.
Even if you're not looking to change, check it out, because it's always it's worth at least spending a little bit of time looking at changes and making sure you're still where you want to be, even if you're happy with what you have.
Yeah. And thank you for having me.
Thank you for having me.
Thank you both so much for coming. Alrighty, and the 7:59 rolling around, I will wish everyone a very good night and thank you very much for coming.
Thank you.